Well, welcome. This is Delaware State Representative Paul Baumbach, and it is 4 p.m. on Sunday. What are we at? April 16th. And it is time for another weekend update on retiree health benefits. I'm speaking slowly to give some people a chance to catch up and join in if they'd like to. So I started this back in maybe December, early January, when I was first appointed to the the Retiree Health Benefits Study Committee, and that has since been replaced by the Retiree Health Benefits Advisory Subcommittee, on which I've also been appointed, and I serve as the vice co-chair with Senator Brian Townsend, and our chair is Lieutenant Governor Bethany Hall Long. We have several members on there from the administration, from retirees, from elected officials, including Senator Brian Pettyjohn and Representative Michael Ramon, Insurance Commissioner Trinidad Navarro, amongst them. So I want to give you an update. It's been 2 weeks since we last met. I didn't do this last Sunday on Easter. And we have our next committee meeting tomorrow. So how about if I bring up that agenda? So what you see is that tomorrow from 4 to 6 p.m., it was scheduled for later in the afternoon, especially for perhaps current teachers who may not get home until maybe 4 o'clock or so that they can join us. And so that's our meeting time. You can join in person or virtually. And if you want to go in person, it's down in Dover at the State Benefits Office on Commerce Way. And generally, maybe 40% or so, maybe 30% of the committee members are there in person, and the rest tune in virtually. So it is Zoom. Please note that you should use that tomorrow's agenda for the link. Those URLs, those links to use do change week to week. So that's the one you want to use. You can also call in, and you can see how you can raise your hand and unmute yourself. We have a relatively straightforward agenda, call to order, introductions. We're going to start with public comment. And one of the reasons is we had initially planned this as almost a complete public hearing, where we really wanted to dedicate the vast majority of the meeting for public comment. We don't know if we've got 2 hours worth of public comment or 20 minutes worth. But we figure by starting with public comment, we can have as much time as the public would like to share their comments. Do also please recognize that as a Delaware public meeting, the public comment is not a Q&A session. We are not panelists answering queries, but members of the public can speak up either again in person or online and share their views. They can ask questions, but it is not the practice of the subcommittee to answer the questions at that time. There are times that questions that are raised by the public interest members of the subcommittee enough that the subcommittee members will then ask that the issue be researched and reported on, likely at a subsequent meeting. So again, it's an opportunity. You'll have generally up to 3 minutes to present your comments, and you can also present them. I'm trying to see if it's on here someplace. I'm not seeing it. But you can also send them, you can email them. So even if it's more than 3 minutes, you can write them up and submit those, and those are then distributed to members. I believe it's SEBC, that's the State Employee Benefit Committee, SEBC at delaware.gov. And I'm going to type that in. So I'm going to say, thank you, and submit comments of any length, including with attachments, to SCBC at delaware.gov. So that is now in the chat. So after the public comments, we will review the meeting minutes from the April 3rd meeting, and then we will look at some additional options. So OPEB, the other post-employment benefits, there's one main post-employment benefit, and that's a pension. Everything else is an other post-employment benefit, an OPEB. And that's all well and good until you end up realizing that you've promised much more than you've set money aside for. And we've done that to the tune of $8 or $9 billion over the past several decades. So we have a big OPEB problem. And so this advisory subcommittee is really tasked to look into that problem and try to identify ways to address that. We'll be doing that for a bit. And as time permits, we'll also discuss our subcommittee has been charged by the legislation that set it up to present a status report as of May 1st, which is just 2 weeks away, to the legislature and to the governor. So we want to talk about what that's going to look like, perhaps talk about an outline for it and how to flesh it out in the next 2 weeks, and then open the discussion up to the subcommittee members, and then we adjourn. So that's the agenda. All this I often say is you can Google SEBC, that's the State Employee Benefit Committee, SEBC. I also do Delaware SEBC Subcommittee Materials. There's 4 words, so I'm going to type that in also. Google the following: Delaware SEBC Subcommittee Materials, and that will get you what you need to. It'll get you to the page. You can then find the Retirement Health Benefits Advisory Subcommittee, and then you can go to the meeting. In particular, in this case, we're looking at the April 17th meeting, and you can get all the materials. And the first piece there is the agenda. So the next one I talked about the next part of the meeting will be, after the public comment and reviewing the minutes, will be looking at how we've explored ways in the past to reduce the OPEB liability, the unfunded amount. This table was shown 2 weeks ago. One of the things I want to point to is these first top 2 left figures. So we've got 3 populations that we provide health benefits to. We have active employees. We have retired employees who are not eligible for Medicare. So that's pre-Medicare retirees. We have retirees who are eligible for Medicare, the Medicare retirees. Because this is a post-employment, that's the PE part of OPEB, we're really not worried about the active employees. That's dealt with separately. That does not factor into the OPEB, and therefore doesn't factor into the OPEB liability. So the OPEB liability, which is measured here as being $8.3 billion when projected out for 20 years, over 20 years. I look at those top 2 figures and I conclude the following: 1/3 of it seems to be attributed to paying health benefits to those pre-Medicare retirees. So if I start work at 25 as a teacher, I work for 30 years to 55, I have 10 years of being retired before Medicare kicks in. And currently for those 10 years, because I put 30 years in, currently for those 10 years, the state of Delaware pays all those costs. And that's really expensive because it doesn't have Medicare. Once I turn 65, Medicare pays about 80% of those costs, and the state is only on the hook for 20%. So it's a very different situation there. We don't have as many people who are pre-Medicare retirees, but we pay much more for each year of somebody who's a pre-Medicare retiree than someone who's also covered by Medicare. And you can see that in this table, these top 2 cells of pre-Medicare as of July 1st of last year and Medicare retirees, you can see that roughly 2/3 of the $8 billion shortfall can be attributed to health benefits provided to those of Medicare age, and only 1/3 to those who are less than 65 years of age. So I think that's interesting. There's other numbers in there. I want to get, I've asked for more clarity on exactly how those numbers fall, and I'm hoping that we'll get some clarity there over time. So what are different ways to reduce it? And so the predecessor organization I mentioned, the Retiree Benefit Study Committee, looked at a whole bunch. We can add dollars to it. We can change when we're paying. We can change the structure of how we deliver those benefits. And they looked at a whole bunch of different things. And so the following pages just summarize that a little bit. So I'll go through that. I just sneeze here. All right. I think that might be it. So the baseline, of course, is if we change nothing, then we have roughly an $8.3 billion shortfall in 20 years. And therefore, if you do nothing, there's no change. So it's good to see baseline. I do nothing, nothing changes. Not very earth-shattering, but important to have there. So starting the current budget year for the state of Delaware, which began July 1st of last year and goes through June 30th of this year, we've started putting 1% of the operating budget into the OPEB fund as an additional funding mechanism, roughly $50 million a year. And because the budget grows with inflation every year, that's set to increase, and they estimate somewhere around a 3.6% annual increase. So that alone, you can see now here we had been, you may remember that other chart went through 2042. Here we're projecting things through 2052. Don't ask me why some cases they're projecting 20 years and some they're doing 30 years. But this presentation, these tables are looking at a 30-year projection. And what it shows is that that 1% alone will provide 60% of addressing that $8.355 billion shortfall. More than half. That sounds pretty darn good. Now, what if we do 2%? Now, I looked at it earlier when I first saw, somewhere in the, it wasn't 60% before, it was like 38%. I said, well, what happens if you double it? Was that going to double it? It does. It's not that good, but it's still pretty darn good. There's mathematical reasons why 2% is not twice the funding ratio of 1%. Doesn't matter right now. But if you do 2%, you're essentially close. You're filling the gap. 93% is pretty darn close to 100%. And if you do 3%, then you're going to get to that 100% based on the projections. So we can solely address the shortfall with adding every year for the next decades, over the next decades, taking 2% or more of the budget, of the state's budget, and use that to just keep adding to the OPEB. And over time, we will overtake that liability, especially if you do 3%. Before we had our first meeting, so I'm the representative for the House Democrats. We've got 4 caucuses: House Democrats, House Republicans, Senate Republicans, Senate Democrats. I represent the House Democrats on this subcommittee. And what I've said is I want to know how we can close the gap solely from the budget. Not because I want necessarily to close the gap solely from the budget, but I want to at least know we can close the gap and use that as our starting point. Rather than say, do nothing as our starting point, I'd like to say, let's fill the gap and then say, you know what, instead of doing 3% for the next 30 years, what if we do 1.5% and do this other thing? But I like to begin with solving the problem and then see if there's a better solution, rather than doing minimal and hopefully getting to a point where we've solved the problem. So I really like this table. I really like this slide. This tells me that, even the 2% range is one that will get us the vast majority of the way, if that's how we want to address the bulk of the shortfall. Okay, what's on the next slides? Okay, so there's who's eligible for the health benefits. If we reduce how much the state pays for a spouse of retiree, and have it so that only half of the costs are paid by the state, then that alone will address the funding shortfall by about we'll call it 20%. What if we shift off when you get when you're eligible? So right now, if you have 15 years of service, you'll get 50% of the cost paid by the state. What if we push that to 20 years of service before you get 50%? Well, that again, if we just do that, that'll do about 20%. So it's actually these standalone pieces can do this standalone amount for the funding ratio. What if we terms of plans entitled to future benefit will not have access to health care? So this is something where if in the case I gave before, I'm 25 years old. I started as a teacher. I stayed working as a public school teacher in Delaware for 30 years. I'm age 55, and I may want to do. Let's say I work 20 years, and I'm 45, and it's time to do a different job, and I whatever it happens to be, become a realtor, let's say, and I bring down a salary, maybe have a 401k. But I stopped being a teacher at 45. I worked another career for 20 years. Then if you don't, so if you term employment, you end your employment with the state, you're entitled to a future pension benefit, but not now, then you wouldn't have access to health coverage. So health coverage would only come if you retire when you're eligible for health benefits. Then that again would address that 18%. And this is one where you can see on the far right column, who does this affect? Well, as an active employee, then the benefits for when I retire are changing, so that's affecting me. And also anyone who is considering joining the state as an employee, they'll look at it and say, geez, that's not as good as it is today. It's not as good as the baseline. So, who's this affect? Active employees and future active employees. And the last one is, what if we increase the required age so that no one gets health benefits until maybe age 55 if you're a state police officer required to retire at age 55, or for everyone else age 60 or more. And that again is maybe a 20% coverage. So that again, if you take the extreme case, so let's say that I start working as a part-time worker. I think it works a part-time worker. It's even say a full-time worker at a state park. And, I'm working maybe the front gate and doing that as an 18-year-old. And by 21, I'm running some nature seminars, and I just keep working through the Department of Parks and DENREC. And after 30 years, I retire. I'm 48 at that point. But what if there's no health benefits until I turn 60? At 48, I've got a lot of time to work on things. So even though I have 30 years with the state, I still would have to wait until 60 to get health benefits. Again, that's a fourth approach here of changing some points when you're eligible. That again, all these things are right around 20% of the funding. So if you look at that 20%, say, well, geez, if we do one of those and one of these, or let's say we do two of these, okay, that's 40%, and we keep the 1% funding, hey, we just did 60 and 20 and 20, we got to 100%. So instead of having to go to 3%, we could do 1% and two of these eligibility reductions. Okay, I can see how these building blocks work together. So that's the idea of these tables here. And then the last one is, now we're really looking at mainly retirees, or at least those who will be retirees during this time. So what if we shift to a health reimbursement account, an HRA, and we start with $5,100 and then we add 2% a year. And this is an approach that some states take. That alone would be designed to, would be expected to save somewhere around 35%. That's sizable. And if that's what we want, we know now the magnitude of roughly how that will impact that shortfall. Or what if we move to a Medicare Advantage? That's one where the state really isn't paying much up front for it. The state still has to pay up front for the pre-Medicare age retirees. But regardless, we could, if we did a Medicare Advantage, if we do the Medicare Advantage, then that's roughly a 25% filling the hole. So again, we can pick and choose. We have Page A, which is how the taxpayers, we take this out of the budget each year. That's one approach. Second one, we can look at when you're eligible to get health benefits. That's the second approach. You've got 4 choices there. Third approach, we change what plan we offer to retirees, how they access it through an HRA or through a Medicare Advantage. So these tables, we've asked for this to quantify, what if we do this? What if we do that? How does this impact the bottom line? How do we address that $8.355 billion projected shortfall? So that's what these slides are for. Is there anything else? I'm going to say footnotes and stuff. So that is what's been presented. The last piece here, this was touched on 2 weeks ago. I want to draw attention to it. I will get to the questions. I want to just go through these first. So this is the last attachment. This is one of the other things that we may be going over tomorrow if we have time. We asked for this, and I really appreciated it. So we were presented at an early meeting. Here's the average cost. So the average state employee, retired employee, they under Medicare, the current supplement plan, if you will, the retiree pays somewhere between $400 and $700 per year, and then the state contributes close to $5,000. And out of pocket, actually that $393, the premium is between $0 and $276, and then but there may be a prescription cost of close to $400. So that overall between $400 and $700 per year out of pocket for the retiree, and the state pays $5,000. Now, you can look at that and say, that's the least cost for the retiree of any of these three sets. We'll go into the sets in a second. And it's the most expensive for the state in any of these three sets. What are the three sets? Medicfil is here in the, we'll call it purple. And navy blue are the various Medicare supplements. So Medigap K, G, F, and N. F is closest to Medicfil. G is also very close. It's about $200 difference, as you can see here. And no, there's no state contribution, not because the state wouldn't contribute it, but because we don't do it now, so we don't know what we would do. Maybe we contribute, 80% of the premium, maybe we do 100%. I don't know what the heck it is. But you can see that and I'm going to use G. I know that F is closer, but G is available to everyone both today and tomorrow, regardless of their age. So let's use G and say for this average person, the total cost is about $3,200. The premiums are about $2,400, about $800 out of pocket. The total cost over in the Medicfil column for this average person is around $5,500. And it's a lot less for Medigap for the same person with the same kind of charges. And then if you go over to Medicare Advantage, which is this, I don't know, pinky purple color, you'll see that that's the lowest cost overall, somewhere between $1,000 and $1,300. No premium cost, but more out-of-pocket cost, but the total cost is still much lower than either of these guys. And we're like, well, that's interesting. So we can say, okay, for overall, when you take the state and the retiree together, for this average person, best system, cost-wise, Medicare Advantage, worst system, Medicfil, in the middle, Medicare supplements. Okay, that's interesting. We said, it's nice to know what the average person is. Well, how about the healthiest person? How about the least healthy person? So we said, okay, give us someone who has the lowest costs, has lower costs than 90% of people currently being served. So that's the 10th percentile. So what you have there is you have really very few out-of-pocket costs. So you've got somewhere in the $100 to $200 a year for Medicare Advantage, and that's a few prescriptions and just a few co-payments or something like that. Okay, so really, really inexpensive. This is the healthiest, probably 65-year-old marathon runner. Okay, for some reason we always pick on marathon runners, but the state is still paying for Medicfil. That $4,900 goes into the pot, and so that you can do that and say, well, that's easily the most expensive for this really healthy person is something like Medicfil. And then in between, again, always in between is this Medicare supplement, and Medigap G is about $2,000. So let's say halfway between the cost of Medicfil and Medicare Advantage. Okay, healthiest, average. Okay, how about the least healthy? Someone who has higher cost than 90% of retirees. All right, what do we have here? Well, we've got the worst plan, the most expensive plan is here, Medicare Advantage on the far right. And we've heard anecdotally, one of the things is Medicare Advantage can work really well when you've got low costs and no real problems on medical issues, but it can get very costly when you have some serious medical issues. And this chart really reinforces that. Medicare Advantage, as this chart shows, it can be the most expensive to the overall system. How much the state's paying, how much the retiree, I don't care. Join them together. Most expensive is right there, Medicare Advantage. And here you've got the cheapest. Actually, it's really darn close. Medigap G, so it's Medicare supplement, is $5,400. You add these together, you're right around $5,400. So what we saw is that if we go to these three, here the cheapest was Medicare Advantage. This is the healthiest, and most expensive is Medicfil. Middle, cheapest is Medicare Advantage. Second, middle one is the supplement. Most expensive is Medicfil. So Medicfil is most expensive for the healthiest and for the average. And then it's the time for the cheapest along with the supplement for someone with an awful lot of health issues. So I would view this and say, all else being equal, and this is a gross oversimplification, I'd rather be here in the middle. I'd rather have something that is really never the most expensive and never the cheapest, but it avoids having someone who has a lot of health problems having to pay the highest amount. So it really protects them. And then what share of this is paid by the state and what share is paid by the retiree is a later question. But I think I like this illustration. I find it useful. This just shows that Medicare, I talk about, the Medicare Supplement G. It doesn't mean it's a set cost, and the footnote in here even shows that this thing here on the left, that even within Pennsylvania, Chester County, you're paying about $272. The average in the state is about $100 less than that. So big difference even within the state. In Delaware, average $219 for Medicare Plan G. For a 75-year-old male non-smoker. So everything else is being equal there. So interesting, doesn't really change much in my mind. History doesn't tell us much more than that. So that's all of the stuff that was prepared for the public for Monday's meeting. So with that, I'm going to take that off and I'm going to start reading through the questions and see if I can help out here. All right, Sherry, that proposed make folks have to wait to retire, get benefits in an older age. It wasn't a great option. So what Sherry's talking about is the option. Let's go to that one. It's the option that says, you can't see that. It's the option that says, you got to wait until you get health benefits. So you retire at 50, you retire at 55, you don't need to, you have to wait until 65, you have to wait till 60 to get health benefits. What's the right way to say this? It's true. It's not a great option. It depends. Well, okay. It is one way to help address an $8 billion hole. So anything that can help is worth considering, in my mind. Not saying it's worth choosing, but it's worth considering. It addresses 20% of the problem. Okay, that's not a bad thing. Now, notice this talks about actives and future new hires. I think the big question here is grandfathering. So I would imagine if we were to do a change, like if the state of Delaware were to do a change like this, we'd have to be very intentional about the grandfathering. And by the grandfathering, what I mean is if someone is 52 now and retired 2 years ago and is getting health benefits, we can't take it away and say, oh, you'll get it in 13 years. Just wait a little bit, because they made their retirement decision based on that. So you can't pull the rug out from under a retiree that way. So you can. I think very few people would want to do that. So I think we have to talk about having a glide path to implement this. And I would view it something where you have to be, have to have maybe fewer than 15 years of service. So maybe fewer than 20 years of service. So you're not that close to a retirement decision, and say, you know what, this benefit of being able to get health benefits before you're even 50, it's how we were able to do stuff in the past, but that got us into this hole, and that just plain is unsustainable. And it's so completely different from how every other company does things. Every company does. We're an employer. We're the state's largest employer. So we do have to put ourselves and compare ourselves to other employers out there. If we say this is a unreasonably generous benefit and it costs a lot, it can contribute 20% to the whole, then I think it's worth considering. But as far as it being a good idea, I think it's hard to define exactly what a good idea is. We're trying to address an $8 billion hole. Nothing's going to be fun. Nothing's going to be beneficial. The question is, do we want to do this pain or that pain or this pain or this combination of things that can do it? We are going to be doing cost savings, which means we're going to be doing service cuts. And whether that be, we take it from the overall budget, we can do fewer things year by year in our state government. That's one thing is painful. That may be how we want to do it. Maybe we want to do a piece of that and a piece of this, a piece of that. All right, so let's get back. Sorry, Sherry's first one. Sherry, we already have a challenge getting and keeping employees such as teachers taking away their benefits. That's not a good idea. So Sherry, I get that. But I think that if I'm an employee and I'm worrying about my retirement, same thing as if you move into a condo association, what's one of the things you should do? Check to see the bylaws of the condo. Check to see what their balance sheet is. If they have no reserves and their roof is about ready to cave in, that's a problem. If I'm an employee and I want to take a job with the state of Delaware because of its great retirement benefits, well, if I say, oh, look, they've got great retirement benefits, I'm going to take the job. Well, that's one way of looking at it. A better way is saying, I really like those health benefits. Do they have the money for it? And the answer right now, today, is no. So I think that it's not a complete depiction to say that we're going to hurt our hiring of people if we cut these benefits for essentially new employees. Because if the alternative is to do nothing, then they're not going to get any health benefits anyway. We have an $8 billion hole. So I think we have to address the hole. I think that will make us more attractive to new employees, but we need to do it in a fair way, a balanced way. So that's my opinion. I'm one person. Okay. Yes, I'm on the committee. It's an advisory subcommittee. But I want to bring that perspective forward to say, I'm very conscious of, especially in a low unemployment, we're near record low unemployment at this point. We need to be really mindful of the impact this has on the hiring decision. But I don't think having a promise of health benefits that's unfunded is very attractive to incoming employees. So I think it's better for us to do our job and to chart a path, a multi-decade path to address this hole, including considering reducing unreasonably generous provisions that we have right now that may have made sense in days when the state had a whole bunch of money and was willing to make promises without putting dollars aside. So sorry, that's me being a tough person on that. Employees and retirees, you're also taxpayers, so those folks will take a double hit. Terry, that's a really good point. So your point is if we're taking, and this was pitched in some earlier slides, if we're having a piece of the shortfall paid for by taxpayers, a portion by retirees, and a portion by active employees. Well, retirees and active employees are often taxpayers. Actually, an active employee working for the state of Delaware is almost by definition a taxpayer. A retiree may have moved to another state, may not be paying the taxpayer portion. But certainly the majority of our retirees are Delaware residents and are taxpayers, and an overwhelming majority of our current employees are taxpayers. So indeed, double hit is accurate. So very good point, Terry. Catherine, charts aren't overly helpful as it only gives bottom line costs between plans not being able to pair the details of the coverage. Catherine, absolutely true. The challenge is that we're on meeting number 7 or 8 or something like that, and it's gotten us this far to get to this level. So we're in public meetings, which limit the amount of time. We want to reserve time for the public. That limits how much we can get there. We've got consultants who are working in some cases 7 days a week to get answers to our questions. And so it's our job to try to get to narrow down the questions to the most concise, meaningful, actionable ones we can to get to the details we need and try to dispense with the details that are factual but not actionable. So, yeah, thank you. Catherine, oops, should read without being able to compare the details of the plans. No, Catherine, absolutely true. We're talking generally about Medicare Advantage. Well, there's a whole bunch of different Medicare Advantage things. I think one of these slides in here, can I do that one? Oh, it was probably an earlier one. Okay. So speaking of the details of the plan, so this is enough to maybe give you a motion sickness or something. So here are all many different Medicare options by state. This is from the previous meeting. What are the costs? What are the retiree costs? What are the state costs? Does it have prescription costs or not? 8 footnotes, a full screen's worth of footnotes. Here are, so this is, we got state retirees. This is how Delaware does stuff. I'll say ignore that right now. There's a lot of changes coming to the Medicare plans. And this presentation, I don't think gets to that, but I think we get, there's a comparison of Medicare to Medigap G. It's identical except for several. Please know that the exceptions have nothing to do with pre-authorizations, has nothing to do with in-network or outside network. Those have to do with Medicare Advantage. That's not what we're talking about here on this slide. And so the details of all the different plans, I'm sorry, I don't mean to go into Medicare Advantage. I really don't. So yeah, there is a lot of detail. Just because you can present data doesn't mean it's useful. So we try to get useful details. Insurance is a very fluid landscape. So what was bid 2 years ago may be completely different than what would be bid next year by the insurance company. So what's happening is evolving. CMS, the National oversight group for Medicare is changing rules, and and Congress is changing rules, and so it's a very moving target, which makes it challenging. Okay. Anna Marie says, Paul, when you say move to a mediocre advantage, I think Medicare Advantage is off the table, not only with our stay, but it's bad and deceptive to people. Why do legislators think it's okay to take away our Medicare and still push Medicare Advantage? So I want to say, if you hear that I'm talking about pushing Medicare Advantage, either I said it wrong or you heard it wrong, and I don't know which. I never expect to be talking about pushing Medicare Advantage. When I talk about HRAs, the health reimbursement accounts, the way that states often do that is to provide a menu of retiree health benefit choices, including often multiple Medicare supplement plans and multiple Medicare Advantage plans. That is not pushing Medicare Advantage. Matter of fact, I think I spent some time on that one slide showing that Medicare Advantage is the most expensive for individuals who have high health costs. So please don't come away from this thinking that I'm pushing Medicare Advantage. I'm not. But again, I'm one member of a committee that is sharing advice with the state employee benefit. Many plans do not cover dialysis. Can a person opt into traditional Medicare Advantage? Catherine, I think you're so. So, Catherine, I'm using MA to mean Medicare Advantage. I don't know if that's how you're planning to use it there. I'm going to stress, I do not think that a Medicare Advantage only plan is good for Delaware's retirees. So I would like to not have any Delaware retiree forced to take a Medicare Advantage plan. Can a person opt into traditional? Again, I'm not sure how you're using your letters there. Maybe you can be a little clearer on your question. I'll try to field it better. So Debbie says, it appears the amount the state is currently paying for Medicare, about $4,900, is less than being proposed for the state's contribution to an HRA. So I want to stop you right there. I want to drill into the term the state is proposing. It's less than is being, I think you meant proposed. There's no proposals. Okay, we're exploring, we're studying, we're not proposing. With HRAs, we have nothing on paper as far as what we're suggesting how it be funded. I have said personally on this call 2 weeks ago, I'm intrigued by Rhode Island's plan, their funding system for their HRA, which does not propose a set amount, say $4,900 or $5,100 per retiree, but rather has it based on the person's age and what the premium cost is for Medicare Supplement G. And so, yes, I know that it's absolutely true that the slides showed that the state currently, on average, provides $4,900 per retiree towards Medicare. Yes, it's true that the slide showed a projection of an HRA using $5,100 with a 2% inflation boost annually. But that is not proposed. That is explored. That is not proposed. Sorry, let me read the rest of your, and I'm sorry, Debbie, but I don't want to go down into a rabbit hole if the assumptions are off there. But let me read the rest of your question. So why wouldn't the state stay with Medicare? Most retirees, I believe, would prefer to keep Medicare rather than having to deal with purchasing their own, especially when they age and become sicker. It definitely puts more burden on the retiree. So yeah, thank you for all of your question, Debbie. I really appreciate it. Keep in mind the HRA, that 4,900 is what it was last year. The 5,100 is what it might be right now, but it's not. When you're doing 20 and 30 year projections, there's also assumptions of what those costs are. The cost of Medicare, the state's cost, has gone up more than 2% a year. And the HRA is something that can be designed to have a set percentage increase no matter what the increase of medical costs are. Now, that's another way of saying the state can make out to the detriment of retirees. So medical costs can be going up 5%, and we're putting into the HRA 2% more than last year. It's good for the state. Costs are only growing 2%, but to the retirees, they're now having more out of pocket than they were the year before. So that's one reason why an HRA can be beneficial. You saw like a 20% or so improvement to the funding level if you go to an HRA. The HRA that was projected again is one approach. It is far from the only one that would be considered if we wish to consider an HRA. Typically, what would be done is the advisory subcommittee would share with the SABC and the governor and the legislature if we think an HRA is worth bidding and what features we would want in it. Perhaps something we would ask for is an age-based contribution, and one which is indexed to what the insurance costs are for each age group in the state of Delaware, so that it goes up with health costs. So we can be recommending that goes into the request for proposal, so that any HRA that is bid and offered to the state is one that has the features that we like. But I think one of the challenges is Medic-Phil alone, the costs are going up high enough that the state keeps having to put dollars into it, and we just don't. We're very challenged with that, and it leads to that OPEB shortfall of multi-billions of dollars. Okay, so Pat, new comments. Let's see there. Okay, the 1% has been talked about as charging the taxpayer. In fact, this is the amount the state taxpayer funds were committed at hiring for both current and deferred compensation. It's not a new surprise expense. Pat, thank you. I completely agree with this. My view is, look, I've been, Pam and I moved here when Mike was an infant in 1990. So, we've been here over 30 years. Today's retirees were doing work for the state that we were residents in while we were here. And to the extent that they were hired and they were working under the assumption they were going to have health benefits when they retired, and then the state, and I was part of it, I was a resident as a taxpayer, we weren't setting aside money for that. I got the benefit, I haven't paid the price yet. So I had the meal and I haven't paid the bill. Pat, you make a really good point, whether it be 1% or 2% or 3% or somewhere in between. If it comes from the state budget for the next 20 years, it is paying what we should have been setting aside for decades. And it is paying for the full services for these retirees who have been state employees for decades, have done their service, and were made promises without having the dollars to back it up. Absolutely, Pat, I agree. So, saying that it's on the shoulders of the taxpayers, I don't think it's necessarily a bad thing, which is why I like at least the frame of saying, let's quantify, if we just did it with a percent of the budget every year for the next 20 or 30 years, let's use that as a starting point. I think it can be a starting point because it's not out of line to have a 100% taxpayer funded solution. So thank you, Pat. Sherry, I was wondering why the offer to take a portion of the excess amount of money over the state budget wasn't given as a possibility for assisting this challenge. Okay. Take a portion of the excess amount of money over the state budget wasn't given as a possibility for assisting this challenge. Oh gosh, Sherry, I'm not really clear what you're saying. So if what you're saying is there are years where we have more money than we expected. In the previous year, we 6 times a year, there's a group called DFAC, the Delaware Economic Forecasting Advisory Committee, and they project what our revenues are going to be for the current fiscal year, the next fiscal year, the next fiscal year, and they keep adjusting it 6 times a year. So it's pretty darn up to date. And there's times that we have, I'll say, pleasant surprises, more money than we were expecting, more money than we were building in for both the current year and for the next year. So I think your question is, why aren't we assuming that we're putting those excesses in good days towards the OPEB? And the bottom line, if that's your question, I think the best answer is we can't count on it. If we could count on it, it would have been built into the budgets. But if we have just some great windfall, great things happen, whatever the economy grows at 5% a year for, real growth of 5% a year for 5 years without causing a recession, leading to a recession and other problems. And it's just good, lots of revenues, our expenses are controlled, and it's great. Well, then, yeah, we should be putting that in there, but we can't and we shouldn't depend on great days ahead. We have to count on normal days ahead. And if we have good stuff, then we can direct that. But that's not going, I'm going to say, a prayer isn't a plan. So we have to work on the likely, and we can benefit from the unlikely positives, but there's also unlikely negatives we need to prepare for. So the best thing, and actuaries do this, is they chart a default path without assuming either best of days or worst of days, and try to find somewhere in the middle. We should, and we have put dollars. I mean, last year we had extra dollars, and we said, indeed, with this OPEB thing, let's put $50 million in, and let's do the same thing this year. But what we really need, I think we really need to do is figure out whatever the amount is, 1%, 2%, something in between. I think we need to put that into the Delaware Code to obligate the state every year for the next 20, 30 years of doing that same amount. And then in good years, we can say, okay, well, we've got some schools that need some extra catch up on their capital stuff, but we also have this OPEB thing. So let's put a third to this, a third to this, and a third to other stuff, whatever it happens to be. And that's what the state does. Is I always say, if there's excess one-time money, put it for excess one-time needs. And if it's excess ongoing money, that can be looked at for new ongoing things or expanded ongoing things. Okay. So let's see if we got this extra money. Okay. Andrea, why isn't Catherine's question on the thread? I see it. So Catherine's question, I have it from 4:26 and 4:27 p.m., but I think she's got an update on. So let's keep reading. Yes, not you, but there are others. Andrea, you're right. Yes, others are talking about Medicare Advantage. This is phrase I use is I speak with my colleagues. I don't speak for my colleagues. There are people on the advisory subcommittee who are private sector, the retirees. There are those who are work for employee unions, so they represent active employees. There are also elected officials, and there's appointed officials from both the legislative and the and the executive branch. Again, I don't speak for any of my colleagues there. I speak with them. Do some of them, and frankly, you have exhibits that mention Medicare Advantage. The law was written, Senate Bill 29 law was written for us to consider all options, including Medicare Advantage, but also including MedicFill. Frankly, I think we've taken more time and slides looking at MedicFill, looking at the Medicare supplements, than we have looking at Medicare Advantage. So yes, it's still being discussed. Frankly, there's a much greater proportion of it being discussed in public comment than there is in the presentations. And I understand that because retirees really felt like they got hoodwinked and got, they got hijacked. So what I'm hearing, that feeling amongst retirees. So they're so shell-shocked by that we're hearing that regularly in each of our meetings of concerns with Medicare Advantage. I think it's been heard loud and clear from those I speak with, including those in the administration and certainly legislators. Yes, it's still in the discussion, but that's not, when I'm testing the wind is not blowing towards Medicare Advantage in Delaware. Certainly not Medicare Advantage only. It's my personal view. Susan, can you clarify the taxpayer increase 1% and 2% again? Does this mean an increase? Okay, so I'm going to pull up a slide before I talk there. That's the one. And we go there. So this is Susan. And she says, is this mean an increase in the set-aside funds for state employee benefits in each consecutive year? Yes. So what this talks about is we have for the current year and for the next year, our budget, our operating budget, not roads, not school buildings, that's the capital budget, but the operating budget is roughly $5 billion. 1% of that's $50 million. We've set aside 1% this year, about $49 million, and the governor proposed setting aside 1% next year, which is around $51 million. We're going to call it 50. what's being proposed is that not only are we doing it for the current year and for the next year, but frankly, what I'd like to see is put it into the Delaware law that says that we have to put 1% or maybe 1.5 or 1 or 2% or whatever it happens to be, the number that we collectively, this process determines is the best choice of all the buttons and dials to adjust to fill this funding gap. We put it into the code and say, before you can spend anything else and plan to spend anything else for the next year, set aside 2%, let's say 2%, set aside 2% off the top, and it's going just for OPEB, okay? Just for the whole, not for the cost for this year's retirees, whether they're under 65 or over 65, but just to go straight for the trust fund to add to the balance. And over 2 decades, 3 decades, if we do 2%, that'll get 93% of it done. So that's what's being discussed. Susan, I hope that's clear. So it's funds to be added to the trust fund. It's separate from the funds to be used operationally for that year's retirees' medical costs. So it's 2 separate amounts. And this one is non-discretionary. It's not, oh, the year is good, we can do it, but every darn year, 2% off the top, 1% off the top, whatever the amount happens to be, to go there. I hope that's clearer. Okay, Catherine. Okay, thank you. Sorry, Catherine. My mistyping. Can a person opt into traditional Medicare if dialysis is not covered in the MA plan, which often does not cover dialysis? Okay, so can a person opt into traditional Medicare? So again, I've got questions for your question, and I apologize for that, Catherine. So I think your question, there's the issue of if you have chosen, or it was chosen for you to be a Medicare Advantage, what are there hurdles? Are there hoops to jump through, hurdles to clear, hoops to jump through to shift to traditional Medicare, a Medicare supplement, for instance, if you're already in Medicare Advantage? Great question. I don't have a great answer. Now, some of this has to do with how it's provided to you. If we have a health reimbursement account approach in Delaware, which we don't have today, but if we move in that direction and we have a list of 4 different plans, 2 Medicare supplements, 2 Medicare Advantages, and let's say you chose one, and then you subsequently need dialysis and you realize it's not covered by Medicare Advantage, and you therefore like to switch it over into Medicare supplement, let's say G, can you do that? I cannot say definitively the answer is yes. I can't definitively say the answer is no. But I know it's a non-trivial question, and it's an important question. It's a critical question that we do need to have a firm answer on. I worry that the actual answer, the accurate answer is it depends. That's a terrible answer, but I think that may be the accurate answer. So we need to discover that more. Frankly, and Catherine, you've raised this with me before, the issue for some of these specialized diseases and treatments and how they're covered differently between traditional Medicare and Medicare Advantage is a highly underreported issue with Medicare Advantage as it was presented to state retirees last year. And it's one which we need to understand better. I'm less concerned about that if we offer choices, including traditional Medicare. There, I would imagine, first thing is, and this was raised, I think we'll probably get to it, the issue of as you get older, you don't want to put more responsibilities on the person to choose their health benefit approach. So there is an appeal to having MedicFill that does everything for you. You don't need to shop for the best plan, et cetera, et cetera. I get that. But do keep in mind, there's a lot of retirees who aren't state employees, state retirees. There's a lot of people on Medicare who are not retired from the state of Delaware, including those who get older and including those who have challenge on their own making those decisions. Fortunately, we have services for them. We have departments to help those who are aging. We've got an insurance commissioner's office who has an arm that works with people to choose what Medicare supplement to consider purchasing. We've got senior centers that will help their members in making those decisions. So do keep in mind that let me see, older individuals in Delaware who have to, who are working with Medicare. And frankly, every American 65 and older, and I know I'm generalizing, is covered by Medicare and has an opportunity to select a Medicare supplement or Medicare Advantage thing. These aren't unique to state employees, retired state employees. This is everyone as they get older has these decisions. So this is not a unique challenge. So I don't think that putting that burden, the same burden that's on an awful lot, tens of thousands of other Delawareans who aren't retired state employees who are old enough to have to make that decision, make those decisions. I instead of just saying we aren't going to do that for our state retirees, I'd rather say let's make sure we're helping all retirees, whether they're a state of Delaware retiree or not. Let's make sure we've got the services to help them make those decisions, especially as they get older and it's harder to navigate that. That's how I think that's a far better approach than just saying, well, we aren't going to do that for our state retirees. Personal, I can easily get overruled, but I'm just going to share that. Okay, Susan got that covered. Pat, proposal for an HRA would be recommended by the RHBS. Then SABC could pursue this. Then the governor's budget legislative process. This is a long path, a lot of potential off ramps. Yeah, it's a complicated path. And I think what you're saying is, I can lay out, oh yeah, we'll be recommending an HRA and it has these pieces, and I'm not saying that, I'm saying we might. But so let's pretend that we do. So let's pretend that this subcommittee says best approach for the state is to have a certain percent go from the budget and to shift to an HRA that has some similar features to the Rhode Island plan as far as funding. All it is a piece of advice to the SABC. Doesn't mean the SABC will do it. Doesn't mean that they put a bid out and they get a proposal comes back that has that in it. It doesn't mean that the governor signs off on things. Doesn't mean it goes into the state budget. There's a lot of hurdles down the road. And I'm not blind to that. And Pat, thanks for raising that. The one thing I would say, and I've said this before on these weekend updates, is if there's something, if there is a path that we, the legislature, and again, not me individually, a majority of my colleagues look at and say, this path would be terrible for our state, maybe for our state retirees, we can pass a law that says we will not do that. The governor has the ability to veto any bills that we pass. We have the ability to try to override any veto. So, if we say, let's say that we're considering cutting off all healthcare benefits for every retiree of any age. Okay, hey, just solve the OPEB funding shortfall. Let's say that there's 5 members of we don't have that many, but let's say that every member from the administration, I know I'm going way off a deep end here. Let's say that subcommittee members who are from, actually, let's pick on legislators. It's not going to work for my example. Let's say every non-legislator on this subcommittee, all the retirees, the representatives of the unions, the state employees who work for the unions, and the administration say, we're just going to eliminate health benefits. Solve this problem. Okay. And we legislators dumb idea. We'll vote against it, but we get outvoted. Okay. So let's say the subcommittee says, we want to do that. Or even let's say the subcommittee says not to do that, but we're hearing that, let's pick on them, the administration is really considering this. We can pass a law that says you cannot stop health benefits for retirees of whatever age. We can put stuff in there. So yes, there's a bunch of paths ahead of us, steps ahead of us, hurdles ahead of us, Pat. Absolutely true. The legislature does have a role in there. And if we're duly concerned, sufficiently concerned that some of those hurdles will not be met, and they're ones that we think is really important for us to pass that hurdle, then we can take some legislative action. We'll see. Guess you have to keep watching long term. Ain't that the truth? Yes, absolutely. Not showing. She seems to be. Oh. You know what? I see everyone's. So sorry. I'm going to go into some techie. I have this posted on 3 different Facebook pages. I have it on my representative page, my campaign page, and my personal page. And now I get it. So Pat's pointing out that Catherine's comments are coming by on a different page. So I'm hoping that I'm phrasing the question enough that you can see what I'm talking about. But Pat, thank you for diagnosing what the heck was going on, because I see it. I thought everyone saw it. But I'm using a service that lets me go across multiple platforms because I want everyone to be able to see this if they get a chance. Keep in mind also that I do save this off and post it on the YouTube channel, which you can catch and share with anyone. Believe it or not, there's a bunch of people who don't use Facebook. So giving them a link to the recording of this doesn't help if they don't use Facebook. So I put on YouTube. You don't need to be a YouTube user to just go to the link and choose today's thing and see it later on. Okay. I don't see any more questions, and we've gone an hour. Tomorrow's meeting is from 4 to 6 p.m. Live stream, in person, taped eventually. We'll be able to catch it later on. I think that's what we got. Thank you for the thank yous. I really do appreciate that. We're coming up obviously on the May 1st, but May 1st is not the end by any stretch. And the SEBC meets the following Monday, and they're expected to take up the question of affirmatively extending MedicFill for another 6 months through June 30th of next year. So we'll see where that goes. Who'll be the author of the report, actual writing? So Pat, great question. What will typically happen is that some dirty secrets here on the site. So the three leaders of the subcommittee, which is the lieutenant governor as the chair, Senator Townsend, and myself as the co-vice chairs, we are regularly in contact with the support staff from the Department of Human Resources. And they do a lot of the initial legwork, and they say, hey, here's something. We're like, yeah, really good. Change this, please. Change this, please. Change this, please. So I would say the initial drafter of it, and we've actually talked about what some of the elements we want in there are, and they'll give us a draft, and then we'll make some adjustments, and we'll do some back and forth until really the three of us are comfortable presenting it to the subcommittee. And this subcommittee is going to be saying, well, no, we want to change this, we want to add this, we want to take that out, and then we need to vote on it. We need a majority of affirmative votes to get it done. So the initial drafting, the initial version, will be started by the staff at the Division of Department of Human Resources, but it won't make it to the subcommittee until the three leaders are comfortable with it in that form. Although in some cases, the deadline may be, hey, we need to vote on this next Monday because it's due a week later. So it may be sort of good enough at that point, and then we wordsmith it during the meeting and finalize it during the meeting. I don't know. This is the first subcommittee that has worked on such a aggressive timing schedule, as far as not a lot of time to get a lot done. But also keep in mind, because of the expected actions of the SEBC, this draft is likely, and because we didn't get into the deep details, this status report is not going to go into deep details because we haven't resolved them. So because we've still stayed, we're at 30,000 feet, but we're maybe 15,000 feet. We're still above the ground of, where the boots hit the ground. So we're still at a relatively high level. The status report is just a status report. I don't believe there's going to be any recommendations in there other than perhaps an extension of time. So I do not think there will be anything controversial in the status report. I think it's going to be just the facts, ma'am. We've met so many times. We explored this. We've considered this. We've found interest in this. We've found some in the public comment. We've seen a lot of resistance to this. Guess what? It's Medicare Advantage. We'll document that and then share it with the governor and the legislature. There won't be any bombshells. Won't be any surprise bombshells because anything in that report you're going to see before we vote on it, and you will see contemporaneously as we vote on it. And again, because of the shifted timeline, I do not expect it to be at a point of having anything that is really objectionable. Pat, I understand. You know what? Okay. Henry, thanks for posting your rest. Pat, I understand. Same people. Yes, we have the same people. They have a different task. They have a different mission at this point. And the initial plan came out of SEBC. This is coming out of RHBAS. No legislators on SEBC then or now. 4 legislators, including the 2 vice chairs, are on RHBAS. So yes, the same individuals, are working on this. I gotta say, I've really enjoyed working with them. They have been extremely responsive. I can be a pain in the butt to work with. I do a lot of redlining things and say, no, you got to change this, got to change that. And they put up with me. So I really appreciate and frankly, some of these presentations, you guys know I'm a numbers nerd. I love seeing percentages. I love seeing dollar signs. And I've said, I need this, and they work on it. And I really appreciate that. I know that they were also involved with doing what the SEDC was directing them to do in the previous iteration. But do understand, I'll say there's a different sheriff in town right now. It's Lieutenant Governor Bethany Hall Long, assisted by Senator Townsend and myself. These are all public meetings. So, you're not going to have a secret report done. This is a very different approach. However, do keep in mind, number one, it's not a final report. Number two, we're an advisory subcommittee. As long as you keep that in mind, I don't think you'll find any surprises. What plans are to use Emsley's draft? Pat, is a great question. I think that Wayne's draft, which was submitted in the past, helps us with the framework, make sure we hit this, this, and this. Wayne's draft was, I think, more specific than we're ready to be, and that would be appropriate for us to be at this time. And I think it was intended, frankly, it was intended just to get us started talking about a draft. And I think he really did a great job with that. So it's not that it's rejected and it's not that it's incorporated, but I think it informs what the structure of the upcoming status report will be. Great questions, as always. And it sounds like that is the last of the questions. So thank you very much. Have a great week. If you can, thank you, Pat, for the comment. If you can, catch the meeting tomorrow from 4 to 6 online or in person, and we'll see what comes of that. If you have questions, please email me. My email is at the top of the screen here. I'm happy. It's what I do. It's my job. I try to field the questions I can. If you're just going to, and it's fine. If you need to vent without a question, I'm not going to respond because I'm going to look at it, but that's it. If you have a question, I'll do my best to respond. Thank you for being so concerned, your commitment. I'd like to be optimistic. I think we'll get through this. I think that the whole tide has turned, and I think we're going to have a far better solution than what was proposed last year. Please take care. Talk to you later.